Now, as you know, as a surgeon, a lot of people find excuses not to be screened. They say that that a colonoscopy makes them feel uncomfortable, or that they don't have a family history of the disease, so why bother? What do you say to people who are thinking that?
Well, the major hurdle is the sort of the day before, is the prep. You know, that's an inherent sort of negative about the test, and there's really no way around that. You need to clean the colon of everything so that when you do the exam that you're able to see the mucosa or the lining of the colon in its entirety. So you want it as clean as possible. There have been some very good advances in the preps that have occurred, tend to be smaller volume. They do what we now call as a split prep, where you do half of it before you go to bed, and then you wake up in the morning and do the other half. So it's smaller bits, so it tends to be a little bit more tolerable. But if you look at studies, it's generally is what the prep is the major hurdle. The exam itself is actually very easy. You generally you'll get some level of anesthesia, whether it's sort of twilight anesthesia or whether it's more of a deep general anesthetic where you're completely out. But the exam itself is actually very well tolerated.
Now, colonoscopies, of course, are the traditional screening method, and as you mentioned earlier, they're still considered the gold standard, the best method for detecting colon cancer. What are you looking at during a colonoscopy? What are you looking for?
So the colonoscopy is both sort of what we call diagnostic, meaning it can find polyps or cancers or other if you have inflammation or other things going on, but it can then be therapeutic. So if you see a polyp, you're able to then remove it at the time. So what you're looking for is normally the sort of the mucosa or the lining of the colon is flat, and you're looking for small areas that are raised or elevated. Early polyps that are seen are generally in the 3 millimeter size, and so they're actually quite small.
About how big is that?
Well, 250 millimeters is an inch.
Okay.
So a tenth of an inch.
Very good.
And the camera itself magnifies your view about 2.5 times, so it looks much bigger than it really is.
The point is that the problem can be taken care of at that moment before the patient even leaves the hospital. Is this, and I want to remind people, these polyps are not cancerous, is that correct?
Correct. These are sort of adenomatous polyps are precancerous polyps. And what makes it so preventable is the two factors. Is number one, there's a very long, what we call dwell period, or time that it takes for a polyp to develop and then grow and turn into a cancer. And that can be anywhere from a 7 to 10 year process. So you have a long time to intervene. The other is that if you remove the polyp, you've then prevented a cancer.